Welcome to the Myasthenia Gravis Foundation of Michigan education event. I'm so excited to be part of the first live event since the start of the pandemic. My sincerest apologies for not being able to be there in person. I happen to also be with my family this weekend, rather urgently. So that is real life. Real life is health, and real life as physicians and as people living with chronic disease. So today I am going to talk about how we as physicians have a role in helping you advocate for yourself. I am a neurologist, a neuroimmunologist by training, and I work up at Memorial Healthcare in Owasso, Michigan. So these are my disclosures, any sort of partnerships that I have with industry in terms of research, speakers bureau, advisory boards. That is all on here for full disclosure. So as the start of today's presentation, I also want to review the fundamentals of myasthenia gravis. Doctor in Latin means to teach, so I would like to bring us all onto the same page about myasthenia gravis, and especially as we go through the rest of the day learning so much about myasthenia gravis. And then I'll give a brief overview about how myasthenia gravis is diagnosed and treated. And then I'm going to start discussing ways to strengthen individual patients' understanding of their own disease and allow patients to self-manage, and then methods for patients to self-advocate for their care that they may be considering. And that will hopefully lead well into your next panel discussion as well. So fundamentally, what is myasthenia gravis? Myasthenia gravis is a neurological disorder, and it's an autoimmune disorder where the body's immune system has gone haywire. And it's most often antibody mediated. And it's actually a disorder that happens at the neuromuscular junction, which is the connection between the nerve and the muscle that communicates and allows for movement of the muscle. So in myasthenia gravis, this area is what becomes dysfunctional. And over here on the right, this is what a normal neuromuscular junction looks like and how this all functions together with the acetylcholine receptors on the muscle fibers. So what causes myasthenia gravis? So antibodies develop that block the transmission at the neuromuscular junction. Most often, these antibodies are against acetylcholine receptors, but they also may be against muscle-specific kinase, so that's MuSK. And then there's some other rare antibodies that we also know cause myasthenia gravis, including lipoprotein receptor-related protein 4 and agrin. So although these autoantibodies, which is what we call these when they attack, mediate the disease, there's even other parts of the body's immune system that are also involved. So the T cells, which is another part of the immune system, the B cells tend to produce these antibodies, but the T cells is another part. So the T cells are involved, cytokines, which are part of the inflammatory system, the immune system, and then complement is very pro-inflammatory. So we start to get some of this inflammation going. So most often these symptoms start off with eye symptoms called ocular myasthenia gravis. Those muscles that control eye movements happen to be exquisitely sensitive to dysfunction in the neuromuscular junction. And a majority of patients progress to a generalized myasthenia gravis within 2 to 3 years, but not all patients. And so this is what, going back, a normal neuromuscular junction looks like on the right, or I'm sorry, on your left, versus a dysfunctional on the right. So you can see this green is where the receptors here are blocked. So this is the acetylcholine receptor here, this little kind of flower looking thing in this cartoon. And then instead, antibodies, this little y is how we depict antibodies often in medicine cartoons. So these antibodies block these receptors, and then transmission cannot occur across this muscle cell. And this is what makes muscles dysfunctional. So, who gets myasthenia gravis? It's still considered a rare neurological disorder, but to all of you sitting in this room right now and listening online, it's not rare because you're impacted by it. And data is suggesting that it's increasing. And this is most likely due to better identification and better diagnostic testing, including our blood testing for those antibodies. In 2022 and 23, the overall estimated incidence, which means new cases, was 3 per 100,000 people. And then the estimated prevalence, which means total cases that we have per year, is 14 to 20 per 100,000 people. So myasthenia gravis can occur at any age. Congenital myasthenia gravis presenting at birth is a whole different genetic condition from this autoimmune form that we're talking about, and will generally not be discussed today. But as you continue to learn about myasthenia, I wanted to at least mention it, that this does exist. Pediatric MG, defined as presentation less than 18 years of age, happens, but it's less common, representing about 10% of cases. We see tendencies for women to peak at two different age ranges, in their 30s and 50s. And then in men, it tends to increase after the age of 50. And we are starting to really dig into some of the ethnic and racial differences as well. So some of the African and Black descent patients have an incident rate that appears to be higher, and ultimately a higher incidence of that ocular myasthenia just impacting the eyes. And within Asian descent, they tend to appear a little earlier, and then with ocular myasthenia as well. And so time will still tell us more about these ethnic and racial differences as this data is still being gathered. However, I think it's important because all human bodies across the world are not the same. So what are some of the symptoms of myasthenia gravis? A drooping eyelid, which in medicine we call ptosis, double vision, which we call diplopia. So this could be horizontal, where you see two objects side by side, or sometimes they blur onto each other side by side, or vertical when they are up and down, and sometimes even blur up and down. Problem speaking, we call that dysarthria. Problem swallowing, also known as dysphagia. So some people, their chin muscles, or their neck muscles will get so weak that they feel like they have to push up on their chin to help them swallow. Problems breathing, shortness of breath, and weakness of their arms or their legs, especially with use. Problems getting up and the stairs, problems using their arms, getting undressed at the end of the day because things tend to worsen throughout the day. And somewhat these symptoms may improve with rest. And that's what we mean by fatigable weakness. I just want to briefly touch on some of the urgent symptoms of myasthenia gravis, on something that would be considered a flare or an exacerbation and a crisis. So a flare is worsening of your baseline myasthenia symptoms, such as double vision and ptosis, that difficulty swallowing and chewing, those weakness of the muscles, especially the arm and shoulder muscles, and then unsteady walking and maybe even some falling from that weakness, especially coming from your hip area. We call that the proximal muscles. And then crisis is when the weakness involves the respiratory muscles, and sometimes respiratory support is needed. And so we as physicians love to avoid crisis whenever possible, but sometimes we certainly can't, and then we aggressively treat the crisis because a recent infection or surgeries can cause crisis. So this is why I want you to always be in communication. This is a way you can advocate for yourself. Communication with your myasthenia clinician on if you have a really rough infection or an upcoming surgery. And then sometimes lack of medicine can lead to a crisis, and emotional and physical stressors. So, physical stressors, including those infections or surgeries, or even sometimes just a trauma, a car accident, a big fall that doesn't even seem related to your myasthenia, can certainly push your immune system in the wrong direction. So, how do we diagnose myasthenia gravis? We take a history about your symptoms that you've been experiencing, and then we perform an examination. So some of us will do provocation tests to bring out that fatigable weakness. Sometimes we use an ice pack on the eye. So if you've ever experienced that in the office, and then we measure how much one's eyelid can raise after the ice pack is on the eye for somewhere between 2 and 5 minutes. And then we do testing to look at the head and neck muscle strength. So some of you have brought your chin forward and had a clinician push back on your forehead. We take blood tests to evaluate for the presence of those autoantibodies to the neuromuscular junction. And you'll hear even more about those autoantibodies later today. Sometimes we do an electrodiagnostic test called an EMG, and that tests the communication between the nerve and the muscle in the peripheral nervous system. We use a rapid nerve stimulation frequently to assist in the diagnosis of myasthenia gravis. So we're stimulating that neuromuscular junction to see if it's dysfunctional. And then sometimes a single fiber EMG is needed. You'll get imaging of your chest because there's immune system tissue in your chest above your heart, because we're looking for something called a thioma. You have a thymus there. And then a thioma is extra tissue that could be producing some of those autoantibodies. Pulmonary function tests as appropriate to determine respiratory status. And then some of you may have even had something called a tensilon test, because those were used for many years, but that's not readily done in the United States or even in the world anymore, as we are learning better ways that we can test patients. So how do we treat myasthenia gravis? And there's going to be information throughout the day about this. So this is a high-level overview. So for symptomatic therapy, we tend to use cholinesterase inhibitors, most often pyristigmine. Oftentimes patients need steroids, typically daily prednisone for a period of time. When somebody is in crisis or an exacerbation state, we might need intravenous immunoglobulin, also known as IVIG, or something called plasma exchange that we call PLEX often. There's traditional steroid-sparing immunosuppressive agents that have been used for years, azathioprine and mycophenolate mofetil. And then there's a lot of our newer agents, and there's going to be plenty of information even in the sponsor area, some of the exhibit hall stuff that's available to you about some of the newer therapies that are available. And they're predominantly into two classes, complement inhibitors and neonatal FC inhibitors. And so as we talk about the immune system, going back to what I alluded to with the immune system earlier, you've got two different types of cells. You've got the T cells and the B cells. And the B cells produce some of these antibodies, like those acetylcholine receptor antibodies. And so the neonatal FC inhibitors start to help remove those antibodies. And then downstream from the antibodies produce inflammatory response, including complement, which is a very pro-inflammatory portion of myasthenia gravis. And that is where these complement inhibitors work. So it's downstream from that. And I like this cartoon because I think it helps talk about the different ways some of our newer therapies work as you might be talking about your clinician about some of these newer therapies. So how do we monitor and how do I, as a physician, want patients to monitor their myasthenia gravis symptoms and help them meet their treatment goals. So this is on the right here, a picture of an MG-ADL profile. And this is a scale that we use to assess the impact of myasthenia gravis on daily functioning. And so this, as you read through this, we can see that this focuses on various activities of daily living, including eating, dressing, grooming, and mobility. So a higher score on this scale indicates worsening functioning, and an improvement of 2 points or even more, but of at least 2 points, is considered clinically significant. This is available for download from the Myasthenia Gravis of America Foundation. I think it's also on the Michigan page. But this is something that you could even keep at home and check in with yourself once a week, once a month, just to kind of make sure that you are heading in the right direction, or at least check in when you feel good so you know how you score when you feel good, so that then when you feel bad, you also have an idea of how bad you really feel. And I think that's a really good objective marker from, hey, I feel really bad today. Am I just having an off day, or am I really bad? As we continue to enhance myasthenia gravis treatment, there are also people who are really working towards how do we help patient experience in myasthenia gravis. And so predominantly in Europe, there was a lived experience by myasthenia gravis survey patient research study. And so it was considered a survey-based study, and it was 7 different countries that was 54 patients with myasthenia gravis that were surveyed. And then they developed a smaller patient council based on the response to those surveys. And they developed domains that myasthenia gravis patients wanted their healthcare providers to know were impacted. So now we're talking about not just treatments, not just hospitalizations, but we are talking about how do myasthenia gravis patients live, and what do myasthenia gravis patients want the healthcare team to know. So the domains that this group developed were the physical symptoms and the impact that myasthenia gravis had on their life, the psychological impact, the impact on their mood, their anxiety, their depression. There is a lot of anxiety about when will another event occur? When might I be hospitalized? The social impact of MG on relationships with others, whether it be with a spouse, with children, with parents, or even in the workplace. Reproductive and parenting concerns, activity and participation in activities outside of the home. Can they participate in their arts activities, their sports activities, be a soccer mom, participate in church activities? Concerns about flare-ups and myasthenia crisis. What is the treatment burden? The treatment burden, whether it be time, financial, pain, sticking yourself or taking a pill. There's a lot of new medicines out there, but if you're somebody who gets poked 9 times every time somebody needs to draw blood from you, maybe an infusion isn't the right thing for you. Or if you are somebody who cannot remember to swallow a pill, these are all conversations that need to be had when we talk about a lived experience by a myasthenia gravis patient. And then what are the continued unmet needs for myasthenia gravis patients? And this leads right into, how do you, as a patient or as somebody living with myasthenia gravis, develop your team and put yourself in a position to be the most successful with your myasthenia gravis? So you need to develop your team, your healthcare team. Generally, it's going to be led by a neurologist for the myasthenia gravis. However, there's lots of neuro-ophthalmologists that also treat myasthenia gravis. Having a good primary care team is super important because there are other aspects that will impact your myasthenia gravis throughout life, and controlling your chronic conditions, whether it be asthma, diabetes, eczema. It's also going to be an important part of controlling your myasthenia gravis. Other specialists as needed. If we need to pull in an ophthalmologist, psychiatry and psychology as we need, and as we build that support network, which is still one of the toughest things that we're dealing with in this, if I call it, post-pandemic world, because I'm not sure we're really post-pandemic yet. Um, Physical and occupational therapists can really help learn the right home exercise program to continue to be active. And that's the goal, is that they give you the tools to continue to be active. A good speech therapist to help enunciate those words when that fatigable weakness is starting. But also speech therapists can give swallowing techniques, tips on how to swallow when those muscles are weakening, or tips on meals when there's difficulties. And then don't underestimate your personal support team. Who in your family or friends can be supportive, and who will you turn to lean on when necessary? And we all know that there are people in our lives that are partners, and people in the world who don't fill us up. So who fills you up and who meets you where you are? And then support groups and attending things like this can help with your personal support team, so that you don't feel so alone with myasthenia gravis. I want you to learn as much as possible about your diagnosis. So attending courses such as this one, you're already at 110% A plus. But look at other online reliable resources. So the Myasthenia Gravis Foundation website has great information. Hospital-based websites, I would stick to things like Cleveland Clinic has a really great information section on myasthenia gravis, Johns Hopkins, Mayo, University of Michigan, Sparrow, they have very good websites as well. Things that have edu or gov at the end of it. Also, anything that's related to the Myasthenia Gravis Foundation. Those are reliable resources. And then continue to attend these education and awareness days in person or virtually as available. There's so much that you can learn from a day like this that you just don't get in an office visit with your healthcare team. And then continuously communicate with your healthcare team. Ask questions during your visit, especially if you do not understand something that was said. Please speak up. I encourage my patients, and I encourage all of you to stay organized. Know your diagnosis. If you have a positive antibody, know which antibody it was, and ideally the date that you tested positive, and keep a copy even if possible, only because as we move between physicians, that can sometimes be more difficult to track down. Or if you are traveling and something needs treatment. Unfortunately, even the hurricanes that came through is another perfect reason that I want patients to have something, whether it be electronically secured on your phone or on email, just a way that we can continuously have information to stay organized, because I want to make sure patients can always advocate for themselves if they end up in a tough situation. Likewise, having a list of your clinicians and their contact information. Maintaining an updated medication list. Knowing your allergies plus the reaction to that allergen. And then keep a copy of your vaccination schedule. So as some of our medications now require us to maintain vaccinations, and we are continuously evolving that and evolving that tracking, I also want to ensure that patients know their vaccination schedule. Here in Michigan, we have a tracking system set up by the state, but there are other states, including those just south of us, that don't have that set up for adults. So we are blessed to be in Michigan with that system set up. But if you go to a different state and something happens, that state might not have access to your vaccination schedule as easily. So talking about self-care, um, eating and food choices. So every time we can try to, eating better foods is helpful as long as it is also affordable. So less processed foods with more lean proteins and vegetables helps. Some of my myasthenic patients and some myasthenic patients in general need to soften their foods, especially later in the day. Um, Eat slowly. You're not a teenage boy shoving food into your mouth anymore. And then rest between bites when needed. Um, Eat sitting up. We really, as human beings, should be eating sitting up, not 45 degrees back in the car. And then, if you're struggling at all to swallow, tilt your head in different directions to figure out a good position to help with swallowing. Exercise is important, but slowly work yourself up towards some aerobic exercise. And I'm not asking you to run a marathon. We do like to see patients up closer to 30 minutes sessions, 3 to 5 days per week. I tend to encourage patients to start off at around 5 minutes, 3 days a week, and then add a minute to 2 minutes per week to that session. So then week 2, try for 6 minutes, 3 times a week. Week 3, try for 7 minutes, and could be walking, especially now that it's cooled down a bit outside. It could be one of those bikes that you put at your feet, and just cycle your feet around. Anything to keep your body moving and help get your heart rate up a tiny bit to keep aerobic exercise going. And let's talk a little bit more about general advocacy. So we've alluded to a little bit of self-advocacy, but I'm gonna hash this back because you need to hear things 2 to 3 times for it to really set in. So educate yourself about your disease. Know your disease. I can be a clinician and a physician that treats myasthenia gravis, but my patients are the ones who live with it and they know their body. I want you to go to your appointments prepared. Think about your 1 to 2 top concerns or symptoms that you would like addressed per appointment. Think about what is truly impacting your life. Don't hesitate to take a second person with you for note taking or to provide a second set of ears. From a therapeutic selection standpoint, if the mode of delivery or the schedule of medication or the financial burden of the medication doesn't work for your life, speak up. And there are non-steroidal agents as well available as therapeutics. So if you're struggling with chronic steroid use, please speak up. Chronic steroids can lead to bone thinning, weight gain, development of secondary diabetes. So if you are struggling with that and would like to at least consider an alternative therapeutic, please do not be afraid to speak up regarding that. Again, know that medication list. Beyond that, if you're on a medication that causes a common lab abnormality like a lower white count than is normally expected, I'd like you to have an idea of that, especially if you're on a rarer medicine. If you are on a medicine that puts you at higher risk of an infection, then I'd like you to also know that so that if you were to present somewhere that is farther away from home, that you or your person who's with you presenting at that place can at least tell that healthcare team there. Those allergies, when you come to a myasthenic doctor, I'd love for you to know your previous medications that you have tried for therapeutics so that somebody isn't trying the same medications, especially if they are not working. And then speak up if your activities of daily living are being impacted. So If you take your own MG-ADL and it's being worsened by more than 2 points over a week, I recommend that you contact your healthcare team, because trending in the wrong direction is not something we want. Look again back when we looked at that study of how patients live with myasthenia gravis. And if you're struggling to think about what do I want to talk about on how myasthenia impacts my life, we can go back to those domains that those patient council came up with, the physical symptoms and the impact that they have, the psychological impact, the social impact. Maybe it's reproductive and parenting. Maybe it's activities and participation in outside life. Maybe it's a flare up and a myasthenic crisis worry. Maybe it's a treatment burden. So these are all things that you can consider discussing, if you want to know what would be the next step for you with your clinician. And then how do we advocate about the disease in general? So we're going to think about joining patient registries as available. And this helps advance the knowledge of the disease. So even like that patient survey that happened over in Europe, there's going to be these kind of events and these kind of clinical trials that might not be therapeutics that you might want to be a part of. There is a myasthenia registry. I don't at this point in time know any Michigan sites, but there are registries that are talking about how people live with myasthenia gravis. Join these patient organizations like the Myasthenia Gravis Foundation, which continues to help raise awareness about the disease. And that helps you become part of the community, both in person and virtually. And then participate in awareness days, whether that be locally with fundraising or locally on a state level, discussing things with state senators and representatives as it might impact funding, or even national with Congress, senators and representatives as it can impact federal national funding. Know that also on the side of this, as some of your clinicians, those of us speaking today, and the Myasthenia Gravis Foundation of Michigan, we are working on access advocacy. So there's those of us who are speaking to you today that work with insurance payers to help reduce access or paperwork burden to getting to treatment with myasthenia gravis. So some insurance policies have not been fully updated to reflect the newer therapeutics. And then even some policies, some insurance policies restrict access to some of these newer therapeutics based on clinical trial enrollment criteria for the drug and not real world patients. So those of us who treat myasthenia gravis patients have to navigate this with payers as we get them to reevaluate their policies. But in all of our minds, we also have to consider costs because newer therapeutics are expensive. But cost analysis is generally performed on just the drug cost, but not on an overall healthcare expenditure. So I consider things about reducing hospitalization or reducing needs for therapy. And then rarely do things include lost time from work or family responsibilities, which is more of a financial burden on the patient or the person living with myasthenia gravis than it is on the healthcare system. But it's a big part of the disease to consider when we can keep people working and keep people active in their family life. And that's a huge part of managing conditions such as myasthenia gravis. And then know that there is an administrative burden that your clinician's office is working through because many healthcare offices are now required to submit these things called prior authorizations for testing and medications. So your clinician says, I think this is the best thing for you. And we submit it to the insurance company and I joke, but they say, are you sure? And you have to go back and say, yes, we are sure for all of these reasons. And it's incredibly common for us to do this for a new therapeutic. Depending on the state and the policies of the state, Turnaround time on authorizations can vary from 24 hours to 30 days. So this goes back to that getting involved on an advocacy level, on a state level, even to help reduce some of this administrative burden. Some insurance policies do allow patients to do their own appeal process, a phone call or a letter. I've had a patient actually get on the phone and tell her story about why this medication works best for her and how living with this condition is impacting her life and why myself and her chose this medication or this therapeutic is the best choice for her. And she said it was one of the most nerve-wracking things she ever did, but one of the most fulfilling things she ever did because number one, she got what she needed and what we agreed on. But she felt like somebody in the room finally understood chronic disease that she was living with. So if you get that opportunity and you are that kind of person that can do it, I strongly encourage it. And so know that we are working very hard with the Myasthenia Gravis Foundation of Michigan, with different institutions to work with payers to help you. We're working with state governments. We're working with advocacy groups to continue to get information out about these diseases. And there are times that we partner with pharmaceutical industries on copay assistance, access to medication to help reduce treatment-related burdens. And so, in conclusion, we've covered a lot, but we've talked about the basics of myasthenia gravis being an autoimmune disease with generally positive antibodies that produce an antibody against that neuromuscular junction. There are many treatments available for the treatment of myasthenia gravis. Symptomatic therapies with parastigmine, immunotherapy with steroids, steroid-sparing agents, the traditional ones, complement inhibition, or the Fc neonatal receptor blockade. So there's a growing interest in medicine and neurology about patient self-advocacy within the MG community with that lived experience survey clinical study that did demonstrate that MG patients are worried about several different domains of how myasthenia gravis impacts their life. And then I highly encourage you toward working towards analyzing 1 to 2 of those problems during each appointment to live with myasthenia gravis and work towards living best with myasthenia gravis. Thank you.